Last but not least, we have Jelmer van Lune. He's a PhD at UMC Utrecht, and he's going to be speaking about physics-guided reconstruction of quantitative MRI from conventional contrast by self-supervising deep learning.
Perfect. Thank you for the introduction, and thank you for the opportunity to talk here today about a project I've been working on for my PhD. Standard clinical eye protocols typically include T1-weighted, T2-weighted, and flare imaging, and these are called conventional MRI generally, and they're used to detect, characterize, and monitor neurological diseases. The signal intensity of these scans is typically a function of intrinsic tissue parameters, so proton density, T1, the longitudinal relaxation time, and T2, the transversal relaxation time. There's also a function of intrinsic parameters, such as the scanner hardware or the acquisition setting used. So, for example, the repetition time, echo time, inversion time, and the flip angle. And this leads to some non-physiological, these extrinsic parameters lead to some non-physiological variability. And that causes, and as a result, these scans only have like relative signal information and like absolute quantitative meaning. And this leads to some limitations. So, for example, it hinders the development of objective biomarkers. It hinders longitudinal analysis, and also data-driven image analysis models are less generalizable than they potentially could be. Quantitative MRI tries to address these issues of conventional MRI by using specialized sequences that are then used to reconstruct the intrinsic properties, so the proton density T1 and T2, as you can see there on the right. And this allows for absolute interpretation and comparison across subjects, time, etc. And this also makes it easier to develop interpretable biomarkers, of course. However, quantitative MRI is at the moment in a bit of a catch-22 situation, you could say, because there's just very little of this data available, and mainly because it requires these specialized sequences that often can be quite lengthy. And also, yeah, because it's not broadly available, this kind of hampers the investigation to actually useful biomarkers. And because there's little evidence, yeah, it's not really adopted in the clinic, these techniques. And this, of course, leads to the data not being broadly available. So yeah, there's a bit of this cycle, this vicious cycle. But what if you could break out of this cycle and retrospectively transform the widely available conventional MRI that's available in almost every hospital and transform it into quantitative MRI using deep learning? We aim to do that using a physics-guided self-supervised approach by directly integrating a physical signal model into the training objective. And because we don't require any paired conventional and quantitative MRI data, we can train our model on like a real-world large-scale clinical data sets that are available, of course. So now, yeah, first to the method. So shortly the data set. So we collected a real-world clinically heterogeneous data set at our University Medical Center from our radiology department. So we have over 4,000 scan sessions from almost 2,000 subjects, and they are over a 6-year period obtained. And each scan sessions contain a T1-weighted, T2-weighted, and flare scan. And also these scans over the years have been taken with a range of different acquisition settings for the repetition time, echo time, etc. And also these scans have been taken on different Philips 3 Tesla scanner hardware. So there's also some variability in that. And these are real clinical data. So we also have diverse pathologies in our data set. So we have, for example, oncology patients, but also neurodegenerative, epilepsy, vascular, etc. So now onto the overview of the proposed framework. It's basically a convolutional neural network with a U-net-like design. And here on the left, we have the input conventional MRI, which gets inputted into the deep learning model, which is basically a shared weight encoder, just convolutional neural network, and they are processed separately by the shared encoder. And then these feature maps are fused together of these 3 different contrasts using an attention fusion mechanism in orange, and that can basically also modulate which features are most important. Then these fused features get inputted into the decoder to then try to generate the quantitative map, so T1, T2, and proton density. And then to train this model, we actually add the physical signal model module that takes as input these generated quantitative maps, but also the acquisition parameters of these, the input contrasts. And with that, we can then basically resynthesize these conventional MRI scans and we can then train the deep learning model by calculating a self-consistency loss between the input and the synthesized images, and we do that using an L1 loss in this case. And that's basically, you teach the model basically this way to generate this T1 and T2 and proton density maps. Furthermore, we add some additional regularization, so for example, total variation regularization, and also a soft lower bound on the proton density map to narrow the solution space a little bit and make the problem easier to solve. Then when we zoom in on the physical signal model, for this we used some established block-based signal models in closed form. So for each contrast, yeah, we have the block-based signal model, and I highlighted in red the quantitative parameters that we want to predict, which are inputted in these equations, as well as the acquisition parameters of the input contrast, so the flip angle, repetition time, echo time, and inversion time. And since there's some variation in these parameters in the data set, the acquisition settings, we hope, or the model can generalize quite well, as we'll see later. So now onto some results. So here I have selected 7 patients from our test set of over 600 patients. So A to G, and these are just patients in the test set with some diversity in pathology. So we have a MS patient, a vascular patient, and also some different tumor patients. And the first 3 rows show the conventional input MRI, so T1 weighted, T2 weighted, and flare. And then our generated quantitative map, so T1, T2, and proton density as well. Then we will look at some numbers. So this is the distribution of T1, T2, and proton density over the whole test set. So this 600 scan sessions with the mean in solid and the standard deviation in the shaded area around it for the white matter and gray matter. And as you can see here, the white matter and gray matter area are quite well separated, and also when we look at the values, they are within ranges of dedicated quantitative MRI acquisitions. And also when we look at the means of these tissue regions, we see similar results. We also grouped the test sets on scanner hardware and also on protocol clusters. So we grouped clusters together with similar echo time and repetition time. I don't have fully time to go into that, I think, but we see that in the white matter and gray matter, the means are very similar. So I think we can say that the quantitative maps are invariant to these sequence parameters and also to the scanner hardware used. We did also some reproducibility tests, which is quite common in quantitative MRI. So this is a patient from the test set that was scanned twice within 3 months, so S1 and S2. And first we see the conventional input MRI, and then the quantitative MRI generated by our model. And they, as you can see, they appear very similar. You can also look at some reproducibility metrics, some voxel-wise metrics. So first of all, the mean voxel-wise difference, which is quite low. Comparable to dedicated quantitative MRI methods. And also when we look at the voxel-wise scatter plots of scan session 1 and 2, we see quite tight clustering around the identity line for all 3 quantitative parameters, and also quite high correlation and concordance correlation coefficient, CCC. We did a similar experiment but with a healthy volunteer as well, prospectively, where we changed the acquisition settings from the distribution in our training data sets, so from the lower bound to the upper bound, so with protocol 1 and protocol 2. So again here, the generated quantitative maps seem very similar across the 2 protocols. And also again, when we look at these voxel-wise metrics, we see that the mean difference, voxel-wise mean difference is very low. And also again, tight clustering around the identity line for T1, T2 proton density with high Pearson R and concordance correlation coefficient. So now to the summary. We proposed a physics-guided self-supervised deep learning framework for quantitative mapping from conventional MRI. And it's basically, with this, we can basically retrospectively transform the widely available conventional MRI into quantitative MRI. And we can just use the routine acquisitions T1, T2, and flare as inputs with no additional scan time to obtain these quantitative maps. One limitation, however, of this study is that we only use homogeneous sequence type at the moment. So for example, for T1 weight, it's only a gradient echo sequence, while in our institution, but also in other institutions, they often use, for example, an MRI sequence, which has an inversion pulse as well. So that's not integrated in this model yet. We also showed that these quantitative maps were invariant to scanner hardware and acquisition settings. A minor limitation is here that we only did the analysis in white matter and gray matter, which are quite big structures, so we should do also a more refined analysis on that. And we also showed excellent voxel-wise reproducibility in retrospective and prospective cases. So this potentially opens the door to large-scale quantitative biomarker investigations in a lot of different pathologies, because we can leverage retrospective data, and this potentially might fasten the clinical adoption of dedicated quantitative MRI techniques. Also, it basically effectively harmonizes data across scanner hardware and sequence parameters, and it's by using these generated quantitative maps, it might improve the generalizability of downstream deep learning models. So that's also a nice thing. And here we show this model to be, that it works on the brain, but it could also be adaptable to other anatomical regions as well, as long as you have conventional weighted data and a good forward model. For example, the prostate might be a nice area to look at, because in radiation therapy, the T2 map can be quite important there, so that might be a nice follow-up study. Thank you for the introduction. Here's a QR code to the preprint of the study. Thank you.